Your doctor probably never told you this, but right now, sitting in medicine cabinets across this country, there are pills that millions of people over 60 are swallowing every single morning, every single night. Pills that their physicians prescribed. Pills that the pharmacy filled without a single warning. And those pills are quietly, systematically, invisibly dismantling their memories. Not in some rare theoretical way. In a clinically documented, research-confirmed, happening right now kind of way. And the cruelest part of all of this is that when the memory starts to go, when the names get harder to find, when the same story gets told 3 times in one conversation, everyone in the room nods sadly and says the same thing. It's just old age. It isn't. Not always. Not even close to always. And today, I'm going to prove it to you. I want to tell you about a woman I'll call Margaret. 68 years old. She did the crossword puzzle every single morning without looking anything up. She remembered every birthday in her extended family without a calendar. Her daughter called her the human Google, sharp, present, fully herself. Then, roughly 18 months after her doctor added a new prescription to her daily routine, that same daughter called me in tears. Margaret couldn't remember what she'd eaten for breakfast. She was getting lost driving home from the grocery store she'd visited every week for 2 decades. She was asking the same question 3 times in a single conversation. Her neurologist was moving toward an Alzheimer's diagnosis. The family was preparing for the worst. But here is what nobody told them. What I need you to hear right now, before anything else. Margaret did not have Alzheimer's disease. Margaret had a medicine cabinet problem. When we sat down, went through every single thing she was taking, and made careful, physician-guided changes, Margaret started coming back. Within 4 months, she was doing the crossword again. This is not a miracle. This is preventable medicine. And what I'm about to walk you through could be the most important information you receive this year. These are the 9 most common medications that could be stealing your memory right now, ranked from frequently overlooked all the way to the most dangerous pattern that almost no doctor is currently warning their patients about. Stay with me through all 9, because number 1 is not a single drug. It is a hidden combination that is affecting millions of seniors at this very moment, and the silence around it is one of the great medical failures of our time. Before we begin, I want to be absolutely clear about something. I am not telling you to stop taking your medications. Do not do that without your physician's guidance. What I am telling you is that you have every right to understand what is going into your body. You have every right to ask questions, and you have every right to advocate for the health of your brain. Staying silent is not safe. Staying uninformed is not safe. Knowledge is not dangerous. Silence is. Number 9, diphenhydramine. Right now, how many of you have a small bottle of Benadryl in your nightstand drawer? I suspect it's a significant number of you, and I understand exactly why. It is cheap. It is available without a prescription. It says sleep aid right there on the packaging. What could possibly be harmful about something so ordinary, so accessible, so widely used for decades? Here is what that small pink pill is actually doing inside a brain that is over 60 years old. Diphenhydramine belongs to a drug class called anticholinergics. That word is going to come up many times in this video, so hold on to it. Anticholinergic drugs work by blocking a neurotransmitter called acetylcholine. Acetylcholine is the brain's primary chemical messenger for forming memories, sustaining focus, and maintaining alertness. When you are young, your brain produces acetylcholine in quantities large enough to absorb a certain amount of interference. When you are over 60, your baseline production is already naturally lower. Introduce a nightly anticholinergic drug on top of that reduced baseline, and the cognitive impact becomes significant. A landmark study published in the Journal of the American Geriatric Society found that older adults who used diphenhydramine regularly faced a substantially elevated risk of cognitive decline, with neuroimaging studies revealing measurable shrinkage in memory-related brain regions. And the drug hides everywhere. Anything on a pharmacy shelf labeled PM, nighttime relief, or sleep formula almost certainly contains diphenhydramine. You may be taking it without even knowing the name. For allergies, ask your doctor about second-generation antihistamines like loratadine or cetirizine. These do not penetrate the blood-brain barrier in the same way, For sleep, I will address safer alternatives before this video is over. Number 8. Proton pump inhibitors. Raise your hand if you have been taking an acid reflux pill every morning for years, and not one person, not your doctor, not your pharmacist, has ever suggested trying to stop. This is one of the most overprescribed medication categories on the planet. And the problem is not simply that people are taking them. The problem is that they are taking them indefinitely, when the vast majority were designed for 8 to 12 weeks of use. Your stomach acid is not just an inconvenience to be suppressed. It performs a critical biological function. It extracts and absorbs vitamin B12 from the food you eat. B12 is not optional for brain health. It is foundational. Deficiency in B12 is clinically associated with memory impairment, depression, nerve damage, and patterns of cognitive decline that experienced physicians sometimes mistake for early Alzheimer's disease. A 2016 study published in JAMA Neurology examined more than 73,000 adults aged 75 and older and found that long-term proton pump inhibitor users had a 44% higher risk of developing dementia compared to people who were not using them. And beyond the B12 connection, research has shown that these drugs may accelerate the accumulation of amyloid beta plaques in the brain. Those are the same toxic protein buildups that define Alzheimer's disease at the molecular level. We are not only talking about a nutritional deficiency, we are potentially talking about a direct biological pathway toward neurodegeneration. Talk to your doctor about whether tapering off is possible. If you remain on these medications long-term for a genuine medical necessity, make sure your B12 and magnesium levels are being tested regularly. Number 7. Bladder control medications. This one genuinely troubles me, not because of the medication itself, but because of how consistently patients are kept in the dark about it. Overactive bladder is real. It disrupts sleep. It causes embarrassment. It diminishes quality of life. When a doctor hands you a prescription and tells you it will help, of course you take it. Nobody explains what it is also doing to your brain. Oxybutynin is one of the most potently anticholinergic medications in widespread clinical use today. It does not stay in your bladder. It crosses the blood-brain barrier with remarkable ease, directly interfering with the same acetylcholine systems that govern your memory and your capacity to learn. Studies have demonstrated that the hippocampus, which is the brain's memory filing center, shows measurable volume reduction in people who use anticholinergic drugs long-term. Not fogginess, not subjective confusion. Actual measurable physical structural change. Brain tissue. A comprehensive 2019 study published in the British Medical Journal found that seniors who used strong anticholinergic medications like oxybutynin for more than 1 year had a 49% higher risk of receiving a dementia diagnosis, nearly 1 in 2. And the early symptoms, forgetting appointments, misplacing objects, losing words in the middle of a sentence, are almost universally attributed to normal aging. The medication is never questioned. Newer bladder medications like mirabegron work through a completely different biological mechanism and carry dramatically less cognitive risk. If you are on oxybutynin and have noticed mental changes, have that specific conversation with your physician. Number 6. Benzodiazepines. I want to be careful here because this category carries weight for many people, and I want to honor that. Benzodiazepines have helped millions of people through severe anxiety, panic disorders, and sleep dysfunction. For many, they were a genuine lifeline during a crisis. I am not dismissing that. What I am asking you to do is hear the science without defensiveness. Benzos work by amplifying GABA, your brain's natural calming signal. They produce short-term relief that is real and often dramatic. The problem is what happens when that mechanism is kept switched on not for days, but for months, for years. A 2022 study tracking over 8,000 seniors across a 6-year period found that those who used benzodiazepines for more than 3 months had a 51% increased risk of Alzheimer's disease. The risk was highest with long-acting formulations like diazepam, which accumulate in fatty tissues, including the fatty tissue of your brain, over time. When GABA is chronically amplified, your brain begins reducing its own natural activity in response. Neuroplasticity, the brain's ability to form new connections, to adapt, to learn, begins to deteriorate. Memory encoding slows. Emotional regulation falters. And the trap is vicious. When you try to stop, withdrawal is brutal. Rebound anxiety and rebound insomnia can be far worse than what you experienced before you started. The drug feels necessary even as it is causing the damage. Never stop benzodiazepines abruptly. This is medically dangerous. Work with a physician on a slow, supervised taper. Alternatives include buspirone for anxiety and cognitive behavioral therapy for insomnia, which research consistently shows outperforms medication for long-term sleep outcomes. Number 5. Statins. Before I explain this one, I need to be precise because statins genuinely save lives. Cardiovascular disease remains the leading cause of death in people over 60, and for many patients, statins are appropriate and critically important. But here is what your cardiologist may not have told you. Your brain is composed of nearly 60% fat. Cholesterol is not the villain in this context. It is structural necessity. It forms the myelin sheath, the insulating layer around your nerve fibers that allows signals to travel quickly and accurately. It is essential for synapse formation. When cholesterol is aggressively lowered systemically, you risk crossing a threshold where the brain cannot maintain its own architecture. The FDA updated statin labeling in 2012 to include warnings about memory loss and confusion as potential side effects, an acknowledgement the agency issued only after reviewing thousands of adverse event reports submitted by patients. A 2023 analysis in Frontiers in Aging Neuroscience found that seniors over 70 using high-dose statins for more than 3 consecutive years showed a measurable increase in mild cognitive impairment compared to non-users. And not all statins carry equal risk. Lipophilic statins like simvastatin and atorvastatin cross the blood-brain barrier more readily. Hydrophilic statins like pravastatin and rosuvastatin have shown significantly less cognitive impact in comparative research. If you are on a statin and experiencing brain fog, ask your doctor whether switching to a hydrophilic version might give you the same cardiovascular protection with less cognitive burden. Also have your CoQ10 levels checked. Statins deplete this compound, and it is critical for energy production inside brain cells. Number 4. Amitriptyline. This one surprises people every single time because amitriptyline is most often prescribed for things that have nothing to do with depression. Nerve pain, chronic migraine prevention, fibromyalgia, insomnia. It is an old tricyclic antidepressant that has been repurposed over the decades for a wide range of conditions, sometimes chosen specifically because its sedating side effect can help patients sleep. Doctors treat the drowsiness as a feature. What they often do not explain is what else that drug is doing. Amitriptyline is one of the most potently anticholinergic medications still in common use today. Its affinity for the receptor sites where acetylcholine does its work is extraordinarily high, higher than many drugs that were specifically designed and marketed as anticholinergics. A landmark 2015 study in JAMA Internal Medicine followed more than 3,400 adults aged 65 and older over a 10-year period and found that high cumulative anticholinergic exposure, with amitriptyline among the leading contributors, was associated with a 54% greater risk of dementia, and the damage was not dramatically dose-dependent in the way people expect. Even low, steady doses over years created significant cumulative burden. The decline is slow, invisible, word-finding difficulties, problems sequencing tasks, a creeping inability to hold complex thoughts, all attributed to normal aging for years before anyone thinks to look at the medication. Alternatives for nerve pain include duloxetine and gabapentin. For sleep, very low-dose doxepin has a more favorable receptor profile. For mood, modern SSRIs are significantly safer for aging brains. Number 3. Antipsychotics. Pay close attention here. What I am about to describe happens every single day in nursing homes, memory care units, and hospitals across this country, and most families never find out it is happening. Antipsychotic medications were developed for serious psychiatric conditions, including schizophrenia and bipolar disorder with psychotic features. They are powerful drugs with significant side effect profiles. Today, they are routinely prescribed off-label to elderly patients who are confused, restless, agitated, or difficult to manage. Not because those patients have psychosis, because they are inconvenient. There are seniors in long-term care facilities right now who are being chemically sedated not for their benefit, but for the operational convenience of understaffed caregiving environments. The FDA issued a black box warning about this practice more than a decade ago, citing an increased risk of death in elderly patients with dementia-related behavioral symptoms. The prescriptions continue. Antipsychotics suppress dopamine, the brain chemical linked to motivation, movement, and executive function. When dopamine is chronically suppressed in an aging brain, the results include flattened emotion, slowed cognition, impaired memory consolidation, and accelerated neurodegeneration. A 2022 study in The Lancet Healthy Longevity, tracking more than 25,000 older adults, found that seniors given antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within 12 months, even with no prior dementia diagnosis. If you have a loved one in a care facility being prescribed quetiapine or risperidone, ask direct questions. Ask why. Ask what the plan is to stop. Ask what non-pharmaceutical approaches have actually been attempted. You are entitled to those answers. Number 2. Paroxetine. This one does not receive nearly the attention it deserves. Paroxetine, sold under the brand name Paxil, is classified as an SSRI, the same family as Prozac, Zoloft, and Lexapro. When people hear SSRI, they hear safer, modern, better tolerated. That is largely true for the family as a whole. Paroxetine is the exception. Unlike every other medication in its class, paroxetine carries significant anticholinergic activity. That one pharmacological difference separates it entirely from its siblings. While sertraline and escitalopram leave acetylcholine largely undisturbed, Paxil interferes with it in a way that more closely resembles the older tricyclic antidepressants than any modern SSRI. A comprehensive 2021 review in Frontiers in Psychiatry found that elderly patients on paroxetine showed measurable declines in short-term memory and verbal recall within the first year of treatment, declines that were not observed in patients taking other SSRIs at comparable doses. The American Geriatric Society has placed paroxetine on their Beers criteria, an official list of medications considered potentially inappropriate for older adults, specifically citing this cognitive concern. The frustrating irony is that paroxetine is frequently prescribed to older adults for anxiety and depression, which is precisely the population it poses the most risk to. If you are on Paxil and you are over 60, ask your physician whether a careful, supervised transition to sertraline or escitalopram might give you equivalent therapeutic benefit without the anticholinergic cognitive burden. Number 1. Anticholinergic polypharmacy. I told you at the beginning that number 1 would not be a single drug. I want you to understand exactly why, because this is the most important thing I am going to say in this entire video. Every medication on this list, taken in isolation, might produce only mild, barely noticeable cognitive effects in some people. A little extra brain fog, a little more forgetfulness, easy to dismiss, easy to attribute to age. But here is what actually happens in the real world. Seniors do not take one medication. The average American over 65 takes 4 or more prescription medications daily. Many take 6, 8, 10, or more, a combination of prescriptions, over-the-counter products, and supplements, often issued by multiple different physicians who do not have full visibility into what the others have prescribed. When several of those medications carry anticholinergic properties, they do not simply add to each other's effect. Research suggests the impact multiplies. A 2022 analysis in Age and Aging tracked over 280,000 older adults and found that those with the highest anticholinergic burden, measured using a validated scoring tool called the Anticholinergic Cognitive Burden Scale, had a 120% increased risk of developing dementia over a 10-year period, double the normal risk, from pills. Pills that most of them had never once been warned carried any cognitive risk at all. Let me make this concrete. Consider a 70-year-old woman named Dorothy. She takes a Benadryl PM every night to sleep. She takes oxybutynin for her bladder. She was recently prescribed amitriptyline for nerve pain in her feet. And she takes an over-the-counter heartburn pill every morning. 3 of those 4 are anticholinergic. Each one, according to the separate physicians who prescribed them, is appropriate and safe on its own. Together, her anticholinergic burden score may sit in a range clinically associated with significant dementia risk, and not one doctor, not one pharmacist has done that math on her behalf. This is not a hypothetical. This is Dorothy. This is Margaret. This is your neighbor, your mother, your spouse. The medical term for what I am describing is anticholinergic polypharmacy, and it may be the single most underreported, most preventable driver of dementia-like symptoms in the elderly population today. Here is what I need you to hold on to as you leave this video. Drug-induced cognitive decline is often reversible. I have seen it personally. When the medication burden is identified and systematically reduced under proper medical supervision, many patients experience a remarkable recovery of mental clarity. Memory returns, personality reemerges, the fog lifts. Your brain is not passive. It is adaptive, resilient, and capable of recovering when it is given the conditions to do so. Here is your action plan. 5 concrete steps you can begin this week. Write down every single thing you take. Prescription medications, over-the-counter products, supplements, sleep aids, occasional pain relievers, everything. Leave nothing out. Then look up each item on the Anticholinergic Cognitive Burden Scale, a free and publicly available scoring tool you can find with a simple search online. It scores medications by their anticholinergic risk level. Next, schedule a dedicated medication review appointment with your primary care physician. Use that exact phrase. A good physician will not be offended. They will be glad you asked. Then ask specifically about deprescribing, which is the intentional supervised process of tapering off medications that are no longer necessary or that carry unacceptable risk. It is a legitimate and growing specialty within geriatric medicine. And finally, if your doctor dismisses your concerns, get a second opinion. A geriatric pharmacist, yes, that is a real and distinct specialization, can perform a comprehensive medication review and flag interactions that individual prescribers routinely miss. Which of these 9 medications are you or someone you love currently taking? Have you noticed brain fog, memory lapses, personality changes, or growing confusion and attributed them to age without ever questioning the pills? Have you raised cognitive concerns with a doctor and been told it was just getting older? Tell me in the comments. This community reads them, and sometimes the most important thing is simply knowing that what is happening to your mind is not inevitable, not permanent, and not your fault. Your brain is worth protecting. Now you have the tools to start.